Our next speaker is Dr. Niranjini Perimpanathan, MBBS, MD, MRCP, UK. She is a specialist in internal medicine and currently working in the BH Hospital Pointpedro. She is going to present and discuss an unusual case of re-emerging infections. Over to you, Dr. Niranjini.
Very good evening to you all. And I would like to thank CCP for giving me the opportunity to present in their very first session. I thought to discuss an interesting case we encountered in the early December. So this is a 54-year-old lady. Okay, so before that, I'm from Pointpedro, the northernmost point of Sri Lanka. And this is our hospital's catchment area, and our hospital is a secondary hospital which serves as a secondary hospital for 5 divisional hospitals. And for us, the tertiary hospital is Teaching Hospital Jaffna, which is situated around 30 kilometers from our hospital. So moving on to the history, this patient is a 54-year-old female who was previously healthy. She admitted with fever for 3 days. It's an acute fever with high spikes fever. And also it's associated with diarrhea, 3 to 4 episodes per day. Also she complained generalized body aches and pains. On further questioning, she didn't tell any headache or vomiting, and she denies any urinary symptoms like dysuria, dark urine, and her urine output has been normal according to the patient. She also denies respiratory symptoms like cough and phlegm. And unfortunately, she didn't receive any vaccines for COVID-19. So past medical history and past surgical history were not significant, and she didn't have any non-allergies. So we did a quick focused examination with this history. On examination, she looked very ill and severely dehydrated. She was febrile to touch with a temperature of 101 Fahrenheit. She was alert and not dystic. She was comfortable. Her pulse rate was 84 beats per minute and blood pressure was 114/78. A quick auscultation revealed dual rhythm and there was no murmur. And lungs on auscultation were clear and the air entries were equal on both sides. Saturation was 98 on room air, and a quick abdominal examination was soft and there was no organomegaly, and especially there is no right hypochondrial tenderness. So based on the history and examination, actually this patient came to us in early December, where we started to get other febrile illnesses together with the COVID cases. So our working diagnosis was initially whether it's a dengue fever or a COVID-19 disease. So as soon as the patient arrived, we have done the RAT at the very beginning, and it turned out to be negative. After that, we have requested the basic investigation with COVID-19 PCR. And in view of her severe dehydration, we have given a bolus of IV normal saline 500 ml, followed by we kept her on IV fluids in view of her severe dehydration. And also in addition to that, we were giving oral rehydration solution after each loose stools. And also she was given paracetamol with each fever. So we received the investigations on day 1, which we sent in the morning. So the full blood count was suggestive of a viral picture with a low WBC was 2,700 and there is thrombocytopenia 81,000. UFR was not very significant. The albumin was 1+ and pus cells were there, but there is no active sediments like hematuria. Liver function test was slightly altered and ALT, AST both were raised and AST was more than ALT. Renal function was quite normal except for a slight increase in blood urea. And CRP was high, 110, and we got the NS1 antigen, which came as negative. Remember, this is the day 3 of fever. So we continued the management as for dengue fever. We kept her on hourly fluids 100 cc per hour because she was very ill and not taking enough. We were keeping her on IV fluids, and the urine output and vitals were monitored every 4 hourly as for a dengue non-leaking phase. And we added the IV cefotaxime in view of to cover the secondary bacterial infection, and she was put on a dengue monitoring chart. With all these, we repeated all investigation on the next day. And we got the report in the night, the COVID-19 PCR, it came as inconclusive. So on day 2 of admission, we are still keeping the patient in the isolation ward, and she continued to have fever spikes and loose stools also continuing, but the hydration was better with the IV fluids. And the vitals and urine output were maintaining properly. So we received the second day investigations at 2 p.m. and the full blood count was more or less the same, except for a small rise in platelet. Liver function has deteriorated further. ALT has risen to 281 and AST has gone to 1200. And unfortunately, we got a serum creatinine of 2.35 milligram per deciliter. And CRP also has risen to 191. At this point, we thought that it's not simple dengue or COVID. We have to change our differential. So in view of the acute febrile illness with hepatorenal involvement, whether it could be a leptospirosis or typhus. In our area, the most common infection at that time was like COVID, and second is dengue, and third one is like typhus. Lepto is, we do get patients with leptospirosis, but not as common as other febrile illness. So we did a thorough examination to look for an scar. And finally, we found an scar on the lower back, just above the navel cleft. It was in a very, very hidden place. So this is not that patient's scar. I didn't take any photos of that patient. So just to tell you all how an scar will appear. This looks like a burn injury or like a bite one with a scab over, and usually found in the flexural aspects, in the axilla or groin area, abdomen, around the cloth line, in the submammary areas, sometimes over the back as well. Most often the patient won't remember anything, any bites or anything like that. So it's our duty to look for a scar in a patient with a suspected typhus. Okay, so once we found out the scar, we changed the management. We started the patient on doxycycline, a 200 milligram stat dose, followed by a 100 milligram BD. So this is happening on the second day. At 4 p.m., patient developed shortness of breath, and we noted there's a reduction in the urine output. She became hemodynamically unstable. Her pulse rate was has gone to 150 beats per minute, and the blood pressure became like marginal 98/70. She was tachypnic with a respiratory rate of 30, and saturation dropped to 80% on room air. And with 5-liter oxygen, she was maintaining around 92. And on examination, there were bilateral fine crepitations. So at this point, we shifted the patient to ETU. Actually, we don't have a separate ICU in Pointpedro, so ETU functions as ICU as well. We have 6 beds with 4 ventilators. So we took the patient to ETU. We stopped the IV fluids, which she was on earlier, and we gave the IV Lasix 80 milligram, followed by a 5 milligram per hour infusion in view of her marginal blood pressure. So we didn't want to give the boluses because of the potentially patient can collapse sometimes. Then we nebulized with the ipratropium, and we had to give bicarb in view of possible acidosis. And despite all measures, she remained tachypnic, so we had to put her on a CPAP, and she was on CPAP from 8 p.m. to next day 5 a.m. So investigations we repeated on day 3, and it shows the liver function test has further deteriorated. ALT has gone to 566 and AST has gone to 2,878. There's a mild improvement in the CRP. And the renal function test, unfortunately, almost doubled within 24 hours. So we got the serum creatinine was 5.06 on the day 3 morning. And ECG, because of the tachycardia and the marginal blood pressure, we did the ECG, we showed a sinus tachycardia, but there were no STT changes to suggest any myocarditis. But the troponin was elevated, 1,632. The reference range is less than 14. The meantime, we got the repeat PCR because the first one came as inconclusive. We didn't know whether the patient is having any underlying COVID or any in the recovery phase of COVID. So we repeated the PCR, which came as negative. So this is the chest X-ray we did on the 3rd day after patient has desaturated. It is showing the bilateral fluffy shadows, which could be possible typhus pneumonitis with or without pulmonary edema or possible ARDS. So on day 3 at 2 p.m., there was no clinical improvement. Patient remained tachypnic. Lungs were showing bilateral crepitation. The saturation was same. There was no improvement with CPAP as well. And she remained tachycardic and blood pressure was somehow maintained without any inotropes. But we noted the urine output has dramatically reduced to 135 ml over the last 10 hours. So at that point, we transferred the patient to Teaching Hospital Jaffna to initiate renal replacement therapy and further intensive care. So this is a case of scrub typhus infection complicated with acute hepatitis, myocarditis, acute kidney injury, and possible ARDS. So this is what happened in Teaching Hospital Jaffna. The patient was managed in MICU initially. She required a non-invasive ventilation. They have done an HRCT arranged, HRCT just to exclude a pulmonary hemorrhage, and it didn't show any pulmonary hemorrhage. There was evidence of pneumonitis with pulmonary edema, but still patient remained oliguric there, so the hemodialysis was initiated. Fortunately, patient tolerated the hemodialysis even with all these unstable hemodynamic parameters. So patient made a steady recovery except for the renal. The hemodialysis was continued on regular basis almost every other day, and the patient was discharged 2 weeks, after 2 weeks, with improvement in renal function. Even on discharge, the creatinine didn't return to baseline. So the further follow-up was arranged at nephrology unit. Since the patient has started to pass urine, they have stopped the hemodialysis and then were able to discharge home without further sessions. Okay, so a few words about our disease, the typhus rickettsiosis. It's a zoonotic disease, vector-borne disease. There are 2 genera of organisms responsible for this illness, rickettsia and orientia. We can differentiate the illnesses into 3 main classes: typhus group, spotted fever, and scrub typhus. So typhus group consists of Rickettsia prowazekii, which causes the epidemic typhus. The vector is human body louse. And there's another organism, Rickettsia typhi, which causes the endemic typhus, the murine typhus. And the rodents are the reservoirs for this bacteria, and they are transmitted by the rat flea. But these 2 illnesses are very rare in Sri Lanka because it's always associated with the poor hygiene and overcrowding and transmitted by the body love. So it's very rarely seen in Sri Lanka. The second group is spotted fever group. They are transmitted by ticks, and there are several species coming under this group. And these, in some part of Sri Lanka, we do get the spotted fever cases. So the third class is scrub typhus. It's caused by a unique organism, Orientia tsugamushi, and the vector is the Chiga stages of mite, which can be found in any domestic animals, dogs and cattle as well. And they have identified about 20 types of antigenic strains in these species. So just a few, few words about the geographical distribution of rickettsiosis in Sri Lanka. If you see that everywhere you can, all part of Sri Lanka is affected, and it varies with the distribution of vectors and the reservoir animals. So time to time, there have been some studies to see the zero prevalence of this rickettsial disease. So I got this information from those studies. The central province has predominance of spotted fever rickettsiosis, and the areas found is Kegol, Mavanella, Navalapitiya, Gampala. And also they have found the patients they have screened had serological evidence for scrub typhus and murine typhus as well, but to a lower extent. The Western province has predominantly scrub typhus. Also, they have found some serological evidence for spotted fever also present. The Southern province has a mix of rickettsiosis. The patients have had evidence for scrub typhus, spotted fever, and also murine typhus. But mainly the north ones, northwestern, north central, and northern province, they are predominantly, they have the scrub typhus group. So this is the latest study which was done in 2014. They have studied the zero prevalence of scrub typhus in northern Sri Lanka, because earlier studies didn't include the northern province during their study serological mapping. So they have done a study in 2014. They have taken about 64 patients who were managed as clinical typhus, and they were able to prove that 54 among them were having evidence of scrub typhus. The antibodies were there. So among the 54 patients, they have done a survey of what are the clinical features they had like. So the mean fever duration is 7.5 days. And importantly, they have found that among these 54 patients, 49 patients had the evidence scar. And some people have lymphadenopathy, and some of them had hepatomegaly, splenomegaly, and some other presenting complaints are headache and pneumonitis as well. So moving on to the clinical presentation of the rickettsial diseases, the patient's usual presentation is acute fever, but they can present as PUO as well. We have seen enough cases who comes on the day 2 with a very acute fever, like very ill-looking, very sick, with associated with severe headache and body aches. So they can present as early as second day of fever. Also, we have seen patients who have gone to GPs 2 to 3 times and still not recovering. The fever is not settling and coming after 10 days as well. So the typhus can present as both ways. And the scar, which is found in the scrub typhus patient mainly among about 25 to 89, and in northern province, we do see a lot of patients with scar. And spotted fever patients can have a macular papular rash. Again, it's not very common. Another striking feature is the CNS involvement. Almost all patients will complain of severe headache, sometimes warrant some brain imaging as well. We have done a CT brain to one patient because she came with such a severe headache with photophobia. And also there was an scar, but still we had to do the CT brain in view of her symptoms, severity of symptoms. So headache is a very common symptom and it's always very severe, sometimes requiring opioids to resolve. And in severe cases, they can present with delirium, tremors, rigidity, and features of encephalitis as well. Some amount of large and small joint pain also common. Liver is usually commonly affected. Usually we can see a mild to moderate rise in the transaminases, and we hardly see anybody going into acute liver failure or fulminant hepatic failure, something. In severe disease or even in normal disease, some people can have lung and myocardial involvement. There may be a mild rise in the troponin, and sometimes you can see the chest X-ray showing some pneumonitis evidence as well. But renal involvement is very, very rare. And rarely there have been some case reports, the typhus fever presenting with acute hearing loss, late onset diarrhea, and pancytopenia, probably due to the hemophagocytosis. So the treatment is very simple. The drug of choice is doxycycline. We have to give a loading dose of 200 milligrams stat followed by 100 milligram BD for 7 days. That's all. If doxycycline is contraindicated, as in the case of pregnancy or small children, we can give the azithromycin. Okay, so this is how typhus fever patients' QHD will appear. Once we start the doxycycline, the fever will definitely settle within 24 to 48 hours. Most of the patients, the fever settles within 24 hours and it touches the baseline soon after we started the doxycycline. So this is the typical appearance. If the fever doesn't subside after 48 hours, we may have to look for another cause for the fever. So finally, the take-home message is any febrile illness with no obvious focus, we have to look for an scar, especially where even though the typhus is endemic in some areas of Sri Lanka, but here now everybody is roaming everywhere. So we have to take a travel history and always keep in mind, if we couldn't find a cause for a fever, febrile illness, we have to always look for a scar, because with doxy, we can completely and the prognosis is very good when you start the treatment, and almost every time the patient will recover very quickly. Okay, thank you for patience listening.